Okay, let's draw some samples off the circuit. In this case, we have a pre-membrane pressure looped together with a post-membrane pressure right there. And if we wanted a pre-membrane sample, we would probably draw it from there. If you want a post-membrane sample, you'd probably also draw it from there. So you have to make sure your syringe is turned in the proper direction. Your stopcock is turned in the proper direction. Here's going to be your steps. You need 2 syringes and an alcohol swab. Every time you go to draw a sample, make sure you come with at least 2 syringes and an alcohol swab. Your process is going to be as follows. Remove the cap. Take great effort to keep this clean. This is a central line, the largest central line the patient's ever going to have. And they do what the nurses say, scrub the hub. Clean that off nice and clean. Now your larger of the 2 syringes, used for waste. Put that on sterilely. Pick the gas you want, pre or post. I've opened it up to post. See my stopcock is open in this direction. Turn it off to the pressure monitor. Withdraw a waste. Now the waste you would draw out of here has to be greater than the volume of this line. This is super important on the post-oxygenator gas because it's looped together, this line is looped together pre and post. That means that the blue blood that's on this side, the pre-oxygenator blue blood, is always coursing through this line all the way over to here. This is blue blood all the way to here. And you want red blood that's out here in the arterial line. So you need to withdraw a waste that's way larger than this line. So you have no venous contamination in this post-oxygenator blood gas. We tell our technicians at one of our hospitals to withdraw 10 mLs, which is many times the volume of this line. And if everybody does it consistently, we'll get consistent results. If you don't draw enough of a waste off of this line, a large enough waste, then this blood gas will not be as brightly oxygenated as this line, and it will appear that your oxygenator is failing. Super important. When you loop your pre and your post together, the waste you withdraw from the post-oxygenator blood gas must be large. Now that I have a waste drawn, and turn that stopcock to 45 degrees, I'm not going to mess with this one. If I turn it up just for a moment, blue blood gets over here, and then later on it turns up in my sample. Leave that stopcock alone. And take this off and get my sample syringe. Put that on. Open. Take my sample. Don't usually need much, less than one drop for an ACT, maybe 4 or 5 mLs if you're doing a lot of labs. There's your sample. You might try and keep yourself clean by putting it back in a package for a moment. Now it's kind of in a bag. Hard for you to contaminate yourself with it. And scrub that hub again. And then preferably get a brand new sterile cap. Some ICUs have these caps that have in them basically an alcohol wipe tucked inside of them. So that when you put it on, it's antibiotic, antibacterial. All right, that's our post-oxygenator blood gas. Open it back up to measure pressure. Open it back up to measure pressure. Now blood is moving along through there again. Your pre-membrane blood gas would be the same thing. You turn it that way. I mean, same thing except for the fact that you would turn it that way. And the waste you withdraw, much simpler. Because this is blue blood all the way through here. You only need to get rid of this much waste. So while if you're drawing a 10 ml waste to get a post-oxygenator blood gas, you just need a 2 or 3 ml waste for the pre-oxygenator blood gas if they're wide together. If your samples are not wide together, that would be similar then to just withdrawing from, say, this post-oxygenator port here. So you might have a pigtail of this length hanging off the pre and hanging off the post and hanging off the second post-oxygenator here, and you would use them this way. Everything's essentially the same, only the concern for an exceptionally large waste has gone away, because now you know exactly how much waste you need. You need to waste more than is in that volume right there. So let's do it again. Let's get two syringes, 2 alcohol wipes, and our port of interest. Open this up. Set the cap aside. I'd rather come back with a brand new clean antimicrobial one. If I got to reuse that one, I'm going to keep it nice and sterile and not let it touch anything. Scrub the hub. Oops, that's my sample syringe. Take the waste. The waste needs to be larger than this, so maybe I do 3 or 4 mLs. Take my sample. Scrub the hub. Put a brand new, fresh, clean, sterile cap back on. Notice that we did not flush into this. You have to be super, super careful if you're going to flush into this. This is an arterial. This could be an arterial line. If you're veno-arterial ECMO, this is an arterial line. If you accidentally infuse something you didn't want into this, it's straight into the patient's arterial system. So we generally don't flush this any more than the necessary. And in this case, I demonstrated this as if we were at a hospital that draws samples very frequently. So we withdraw a waste. If there's a clot in there, we pull the clot out, and then we take our sample, and then we just cap it. If you don't take samples frequently, then you may need to withdraw a waste, draw your sample, and then screw onto that a HEP flush solution, tap any bubbles out of it, and inject some heparin flush to fill this line. And if you had one of these, cap it way down, clip it way down there. It also helps if you keep them up here. So I'd get a piece of tape and I'd tape it up in this direction. If you leave it dangle like this, blood, and you don't have a thumb clamp on there, blood fills this with red cells and plasma, and this whole thing becomes whole blood and can clot. So flush it with a heparinized solution. HEP flush solution is usually 1 unit of heparin per 1 ml. Push this way down. Cap that off so blood can't get up there. Keep this up here, a piece of tape on it. That would help maintain the patency of your sample boards.